Hello, this is my health assessment video for NR509. I'll start by doing the scan of the room. Scanning my environment. Scanning the ceiling, scanning the floor. I will start by introducing myself to the patient. Hello, artist. I'm Tina. I'll be doing your physical assessment today. Artist is my son. I give permission for this video to be recorded, to be submitted to Chamberlain for grading purposes. I'll start with the face, and I'll say I don't see no lesion, no discoloration, and I'll note that the head is midline. I don't see no deformity. I'll go by palpating the lymph nodes. Preauricular lymph node, postauricular lymph node behind the ear, occipital lymph node behind the head, tonsillar lymph node, submandibular lymph nodes, and submental lymph nodes under the chin. And I'll go to the anterior cervical lymph nodes, posterior cervical lymph nodes, and I'll end with the supraclavicular lymph nodes right above the clavicles. And did you have any pain with that? And I didn't feel any enlargement, and the patient denies any tenderness. And next I will go with the cranial nerve number 5, which is trigeminal nerve. And to do so, it has a motor and sensory component. Starting with the motor component, I'll place my hands over the maxillar muscles and have the patient clench. I didn't feel any distortion, and he has great strength bilaterally. And next, this starts at the sensory portion of the cranial nerve number 5, the trigeminal nerve. And I have the patient close his eyes and tell me where you feel my touch.
Forehead, nose, cheek, chin.
And the patient was able to identify all those areas correctly, so cranial nerve number 5 is intact. And next, I'll do cranial nerve number 7, which is the facial nerve. To do so, I'll have the patient to do some facial expression, smile, frown, raise the eyebrows, puff out your cheeks, pucker your lip. And I'll say that all the facial expression were symmetrical bilaterally. And next, I'll palpate the tympanic mandibular joint, the TMJ. I have the patient open and close his mouth. And I'll say that I didn't feel any subluxation, any clicking, or any crepitus. And next, I'll assess the patient ears. I'll start by just looking at the ear. I'll say the ears are symmetrical. I don't see any nodules or lesion. And I will get my otoscope, and I'll look inside of the patient's ear. I'll put the ear down and back, looking inside of the, looking at the external auditory canal. I don't see any redness, any drainage, any swelling, or any cerumen. And I'll say the tympanic membrane is pearly gray with no effusion. I'll do the same on the other ear. Pull the ear down and back, looking at the external auditory canal. I see there is no redness, there is no drainage, no swelling, or cerumen. I see the tympanic membrane is pearly gray with no effusion. And now I will palpate the patient peanut on both ears for any tenderness. Tell me if you feel any pain. I didn't feel any nodule, and the patient denied tenderness. Now I will palpate the tragus in both sides in front of the ear. Any pain?
No.
The patient, I didn't feel any nodule. The patient denies tenderness. And next I'll assess the cranial nerve number 8, which is the acoustic nerve. And to do that, I will have the patient cover one ear. I'll do the whisper test, and I'll have them repeat what I whisper to you.
1, 2, 3.
Okay. And next on the other ear.
4, 5, 6.
Okay. And the patient, he identified all the words correctly. So hearing is intact bilaterally. And next I'll assess the patient eyes. And I start with the conjunctiva and pulling it down. And I note that the conjunctiva is moist and pink in color. I don't see no lesion, no drainage. And I'll say the clera is clear and white. And next I'll assess cranial nerve number 2, which the optic nerve. And for first I'll do the pupillary response to light. With my light source coming to the side, have the patient look at my nose. Look at my nose. Coming to the side. Let's see the pupil constrict. Coming to the other side. I'll say the pupils are 2 millimeter on size, equally responding to light. And I'm still on cranial nerve number 2, which covers central vision. I'll use my snare eye pocket chart. Stand up. Stand up. And I'll stand 6 feet away and have the patient cover one eye and read the smallest line you can.
LPED.
All right, the other eye. Stop moving.
ED.
Stand straight. Cover. Read.
LPED.
All right, now read with both eyes and cover.
LPED.
All right. Stand. And I will say that the patient he's able to identify all the letters. He has 20/20 vision on the left, right, and both eyes. I'm still on optic nerve, cranial nerve number 2, the optic nerve, which also covers peripheral vision. And I'll have the patient stand straight, look at me. And then you tell me when to see my hands, okay? Can you see my hand now? Tell me when to do.
Now.
Okay. Do you see my hands now?
No.
Tell me when to do.
Now.
All right. Coming from above. Do you see my hands now?
No.
Tell me when to do.
Yes.
All right. And the patient has good peripheral vision. Have a seat. And next, I'll palpate the patient's sinuses, start with the frontal sinuses. Tell me if you have any tenderness, any pain.
No.
And now the maxillary sinuses, any pain?
No.
And the patient doesn't report any tenderness. And next, I will go I'll back to the eye. I'll say cranial nerve number 3, 4, and 6. Number 3 is the oculomotor. Cranial nerve number 4 is the trochlear. Cranial nerve number 6 is abducent. And to do that, they control the external ocular movement of the eye. And to do that, I'll have the patient follow my finger with just the eye, and I'll make the H pattern. Look at my nose. And look, I'm watching the patient gaze. And I'll say all EOMs are intact. And next I will move into the patient nose. And looking at the nose, I'll say it's symmetrical. I don't see no obvious distraction, any fracture. And I'll get my light source and look inside the patient nose. Tip the nose up. Looking inside the nose. I'll say the turbinate are pink and moist. And I'm looking at the septum. I want to say it's straight in midline with no deviation. I'll do the same on the other side. Tip the nose up. Looking at the turbinate, that pink and moist, no redness. And the septum is midline straight with no deviation. And next I will go with the patient mouth. Start with the lips. I'll say the lips are pink and moist. Now show me your teeth. And looking at the patient teeth, I see there is no cracking, no obvious decay. And open your mouth. And looking at the gums, they are pink and moist. There is no bleeding, no swelling, no lesion. The buccal mucosa is pink and moist. The upper soft and hard palate are pink and moist. The posterior pharynx, they're pink and moist. I don't see no postnasal drainage. The tongue is smooth, pink and moist. And lift the tongue up. And looking at the floor of the mouth, it's pink and moist. I don't see no lesion or redness. Open your mouth again. And the patient does have the tonsil. I'll say it is midline, no swelling. I'll rate them as a 2+, which is normal. They are midline. And next, I will do the cranial nerve number 9 is the glossopharyngeal, the gag reflex. We'll be testing it for this video. And the cranial nerve number 10, which is the vagus nerve. I'll have the patient open the mouth and say, ah.
Ah.
And I will say that the soft palate and the uvula rises symmetrically with phonation. And now I'll do cranial nerve number 12. 12, the hypoglossal. And to do that, I have the patient stick the tongue out. That's right. Move it around. Okay, I'll set the cranial nerve 12 is intact. Now I'll do cranial nerve number 11, which is the spinal accessory nerve. I'll place my hand on the patient's shoulder, apply resistance, and have the patient strike the shoulders. And the patient was able to perform correctly. Next, I'll examine the patient neck, which I'll say is symmetrical. There's no obvious deformity. I'll palpate the trachea, and that is midline. Next, I'll palpate the thyroid gland, localize the thyroid gland, retract on one side, swallow. I'll do the same on the other side, localize the gland, retract, swallow. I didn't feel any nodule or enlargement there. Next, I'll palpate the carotid artery one at a time. Good. On the other side. And they have 2 plus and pounding bilaterally. And next, I will auscultate the carotid artery using the bell of my stethoscope. And then while I do this, I'll have you take a deep breath and hold, okay? Take deep breath, hold. And breathe. I'll do the other side. Take a deep breath and hold. Breathe. And I didn't hear any bruises bilaterally. And next, I will move to check the. Next, I'll do the range of motion of the patient neck. Start by flexion. Look up at the ceiling, extension, and look over your right shoulder. Look at the right shoulder. That is rotation. And put your ear to the right shoulder, ear to the left shoulder, and that is lateral flexion. And the patient is able to perform the activity, has good range of motion of the neck. Next, I'll assess the patient chest. And looking at it, I'll say it's midline. There is no obvious deformity. It's symmetrical to the patient body. And next, now I'll auscultate the heart sound, starting with the diaphragm of my stethoscope. Just breathe normal. Listen at aortic second interstitial space, left external border. Pulmonic area, second interstitial space, left external border. Erb's point, third interstitial space, left external border. Tricuspid, fourth interstitial space, left external border. The mitral, fifth interstitial space, left external border, midline. And I'll repeat the same with the bell of my stethoscope. Aortic valve, pulmonic area, Erb's point, tricuspid, and mitral area. And I'll say I didn't hear any abnormal heart sound in any of those areas. And next I will listen to the patient. I'll listen to the patient lungs. I'll start with the interior. Every time difficult, I want you to breathe. Take a deep breath, okay? Deep breath in. Breath sounds are present and clear in all those areas. I have the patient stand and turn it back. And I'll assess the posterior lung. Take a deep breath. I'll set breath sounds as present and clear in all areas. Have a seat. Next, I'll test the patient hands. Put your hands like this. And looking at the finger joints, I don't see no redness, no swelling, no deformities. I don't see any nodules. And I'll check the capillary refill on both hands. I'll press in each finger. And I'll press until I feel the nail Baritone white. And the patient have a good capillary refill of less than 3 seconds. And next I'll set the grips strength. And I have the patient squeeze my hand. I'll say the patient has great strength. It's 5x5 bilaterally. And next I'll check the patient radial pulses. And I'll say there are 2 plaques present bilaterally. And next I'll check the cerebellar coordination by having a patient do 2 type of exercises, rapid exercises. Put your hands like this. Face up, face down. And I'll have you turn it quickly. Repeat that. That's very good. And next, I will do have your index finger to your thumb, middle finger, forefinger, ring the last finger, and I'll keep doing it faster. And the patient was able to perform both exercise well, and I'll say the cerebella is well coordinated. Next, I'll assess range of motion of the elbow. And for this video, I will do it unilaterally, but in a true assessment, I will do it bilaterally. Starting with the elbow, I'll do flexion, extension, and I'll range of motion of the shoulders. Start with the shoulder, I'll do extension, flexion, and I'll do internal rotation, external rotation, internal rotation, external rotation, abduction, take it away, adduction, take it in, and I'll say the patient has good range of motion of the shoulder. And next I'll take the tricep and bicep strength, have the patient do the elbow like this, pull against my resistance, pull. And I'll say the patient has great strength, 5x5 bilaterally. And next I'll test the patient deep tendon reflexes. And to do so, I'll support his arm. And I'll start with the bicep. I'll put my finger in the intercubicular fossa area, and I'll strike my thumbnail with the pointy part of my hammer. And I see the patient have brisk response. And I'll do this unilaterally also. I'll do the patella, and I'll strike the patella with the flat end of my hammer. And I see the patient had good response. And I'll do the Achilles, relax. And I will dorsiflex and support the foot. and I'll strike the Achilles with the flat end of my hammer. And I see the patient have good response. Next, I will move into the abdominal exam. I have the patient laying on the bed, and I'll move my camera. Lay down. Put it like this. Okay, get my stethoscope. Scoot up this way. Scoot this way. I will expose the patient's abdomen. And looking at the patient abdomen, I don't see no lesion. I don't see no swelling. The abdomen is symmetrical. It's flat. And next, I'll auscultate the abdomen in all four quadrants. The bowel sounds are present in all four quadrants. Next, I'll auscultate using the bell of my stethoscope. Auscultate for any bruise. Starting with the aortic artery, which is midline above the umbilicus. Now I'll do the renal areola lateral above the umbilicus. I'll do the left renal lateral and above the umbilicus. Now the iliac artery, left iliac artery, which is below and lateral to the umbilicus. And I didn't hear any bruise in any of those 5 areas. And now I will go, I'll palpate in all 4 quadrants and tell me if you feel any pain. Any pain? And the patient denied any tenderness. I didn't feel any enlargements, any masses. And next I will percuss in all 4 areas. We percussing for any dullness, any flatness, any tympany, and I didn't hear any of them in any part. And next I will assess for lumbar sign. I will hold my hand at a 90-degree angle, press down, and tell me if you feel any pain, okay? And I'm assessing for any rebound tenderness. Any pain? Pain? And the patient doesn't report any tenderness, that would be negative lumbar test sign. Now I'll put my hand and I'll palpate the liver. Take a deep breath. And I'm pressing down, deeper and upward. You might feel the edge of the liver. You feel? And now I'm going to palpate this plane, lay this way. Looking at the edge of the rib cage. Deep breath. Looking at the spleen. And I didn't feel the spleen, which is a normal finding. Now I'm looking at the lower extremity bilaterally, and I don't see any swelling, any edema. And I'm checking the patient dorsalis pedis pulse bilaterally. They are present, pounding 2 blocks bilaterally. Next, I will check the range of motion of the knee, and also we'll do this unilaterally. Start with flexion, extension, and we said range of motion of the hip. When I flex the knee, we stretch the hip. I'll do the internal rotation, external rotation. I'll do abduction, take it away, abduction, towards, and the patient has good range of motion after knee. Then I'll do the bilaterally strength of the knee. Do this. Okay. Pull, push, pull. He has 5x5 strength bilaterally of the knee. Now I'll say range of motion of the ankles. Dorsiflex the foot, plantarflex the foot, and I'll rotate. And I'll say the patient has good range of motion of the ankle. And I'll assess the strength. And I'll push my hand, pull down, good job. And then dorsiflex, push against my resistance. The patient has good strength bilaterally on the ankles. And now I have the patient stand back up, stand over here. Move over here. Okay. And for this part, go back. This is the lumbar test. I'll have the patient stand with his eye closed for 20 seconds and we're checking for any sway. Has the patient stand? I don't see any sway, so I'll say this is a negative lumbar test. Open eye. Now I'm testing the range of motion of the spine. I have the patient flex, touch your toe. Now lean backwards like this. Look at the ceiling. I'll say now twist. That's rotation. Twist. And I have the patient bend at the hip. On the other side, that's lateral flexion. So the patient has range of motion, good range of motion of the spine. And now I have the patient take a few steps forward. Keep going. Turn back. I'll say the patient have even steady gait. And next I'll check the spine. Turn around. I'll palpate the patient's spine for any masses, any tenderness, any deviation. Turn around. I didn't feel any masses or any deviation. Do you have any pain with that?
No.
And the patient denied any pain. And that concludes my physical assessment. Thank you for watching.